Over to you, Dr. Prasad.
Okay.
I hope you're the host now.
Still not allowing me to share the screen.
Oh, maybe I think I made the other one. I think you have two accounts, right?
Oh, okay.
1 second. I'll make the other one this one.
Yeah, I just disconnect. Yeah, that's right.
Shall I make you the other one as host?
Yeah.
1 second.
Okay.
One second.
Maybe I can
Nah,
log off of the other one. Would that make it better?
just check it right now. Is this the one? No?
No.
Yeah, please check that now.
No, it says
You're the host now.
no, it says host disabled participant screen
Yeah,
sharing.
1 second. 1 second.
Okay. Rohan?
Could you get it now?
No, let me just close the other one.
Yeah, please, please. Please let me know once you close the other one. Yeah, that's closed, right? Now you're the host, Dr. Prasad.
Oh, okay.
Are you able to see that?
Yes,
Yeah, thank you.
finally. Technical glitches. Thanks, Ishwar Chandra, for the kind introduction. It's always an honor and pleasure to be able to give this talk named after the esteemed radiologist, educator, researcher, and a role model for many of us. In the next hour or so, we are going to see a wide spectrum of fibro-inflammatory disorders that show tumefactive growth pattern. Inflammation is, for the most part, a beneficial process that allows the body to contain foreign bodies and infectious agents and allow the body to heal. When inflammation is persistent or disproportionate, or it leads to exuberant fibrosis, we enter the world of fibro-inflammatory disorders. There is a diverse spectrum of these disorders that mimic and masquerade as tumors clinically, pathologically, and on imaging studies. A subset of these disorders are in fact neoplastic, with characteristic tumor genetics and distinctive tumor pathways. As with most other things in radiology, the imaging findings reflect whatever we see under the microscope. And it is important to distinguish some of these things from other cancers and sarcomas with which they are confused with, so that we can do the best treatment option and optimal management of these patients. One of the joys and distinctive advantages of being in academic radiology is that one gets to see a variety of truly rare cases that stimulate our otherwise inert brains, makes our days interesting, help us understand disease processes in a better way, which in turn helps us take better care of our patients. Here are some representative CT images in a young woman with abdominal pain. As you notice, there are multiple nodules and masses within the omentum and the peritoneum. So some of the things that immediately jumps to our mind is this patient having a really bad tumors such as peritoneal carcinomatosis from GI tract or GYN primaries, or peritoneal mesotheliomas, or if I'm in India, definitely one cannot rule out tuberculosis. So this was a young woman who was complaining of pain. She had a CT scan immediately after the C-section, which was apparently normal. And these images are 3 months after the C-section. This is an extremely rare case of Vermix caseosa peritonitis, which is due to an inflammatory response to spilled amniotic fluid. It actually presents as an acute abdomen, and it's quite characteristic cheesy white exudates that coats the peritoneum as well as the visceral organs. It has a classical histopathology, and peritoneal lavage is the mainstay of treatment. There is another patient who presented with acute sigmoid diverticulitis. You see the classic inflammatory changes, and usually most patients will have resolution of these changes following optimal treatment. Whereas this patient presented 2 years later, and he presented with left flank pain due to this fibro inflammatory mass at the same level of sigmoid diverticulitis 2 years before. So clearly there is disordered inflammatory and fibrotic response that led to the left urethral stricture. Here are some CT images in a patient who was a 61-year-old Vietnamese man with 2 months history of pain and fever, anorexia, all classic symptoms that one could ascribe to bad cancer. And sure enough, he had an ultrasound at an outside facility. The liver was diffusely abnormal and he was referred to us. And when we scanned him, obviously we saw innumerable large, ugly looking heterogeneous masses within both lobes of the liver. And there is a common assumption that anyone walking through the doors of MD Anderson invariably has cancer, and particularly advanced cancer. So, but before any treatment is instituted, thankfully we do biopsies, and the biopsy was truly interesting. And based on the biopsy and pathological findings, he was given some treatment, and voila, I mean, clearly there is remarkable improvement in the liver masses. And the biopsy had showed liver tissue with dense fibrosis with mixed inflammation, composed predominantly of lymphoplasmacytic cells with focal neutrophils and histiocytes. So also referred to as the inflammatory pseudotumor. Inflammatory pseudotumor is a common rubric under which category we see not only true abnormal proliferation, which is non-neoplastic in nature, but also under this category of broad category of abnormalities comes the inflammatory myofibroblastic tumor. So in essence, inflammatory pseudotumors can be non-neoplastic as well as neoplastic. And the importance of knowing this is that these respond exquisitely to steroids or immunosuppressants. Here is another patient with chromophobe renal cell carcinoma with some pimples, I would say, in the liver. There's an intensely enhancing central portion with ill-defined hypervascular perfusion-like changes surrounding it. And this patient, since it is known that the chromophobe renal cell carcinoma of all the other subtypes have a predilection to involve the liver, they wanted to rule out or exclude metastatic disease in the liver. And lo and behold, this was another case of inflammatory pseudotumor. Another patient with clear cell renal cell carcinoma, again, one of the most common subtypes of metastatic renal cell carcinomas is clear cell carcinomas. In fact, 95% of all clear cell renal cell carcinoma, metastases are from clear cell renal cell histological subtype. So again, biopsy was performed on these multiple liver lesions such as these, hypervascularity with a central scar, as opposed to the intense enhancement seen on the prior case. So clearly there is no set pattern. And this again is a case of inflammatory pseudotumor. One of the first descriptions of the so-called inflammatory pseudotumor was in the thorax. In fact, it's the most common pediatric lung mass. So one of the things about inflammatory pseudotumors is the classic demographics, usually children and young adults. And there is a prior history of antecedent pneumonia in many of these patients. And there is a predilection to involve the lower lobes and in the peripheral location. And they're frequently large heterogeneous mass when diagnosed, and some of them may have dystrophic calcifications. The important thing to remember is that if not removed with a healthy margin, they tend to locally recur. And lungs are one of the classic locations for inflammatory pseudotumor that consists of spindle cell proliferation with chronic inflammatory infiltrates. It includes, as already alluded to, both reparative non-neoplastic entities. In most of the pediatric ones, it's usually the non-neoplastic entity. And the other part of these are the so-called inflammatory myofibroblastic tumors. Another classic location of inflammatory pseudotumor is the spleen. Notice that there's a large hypoechoic mass and hypodense mass. And, usually in the context of the classic demographics, that's one of the common things to consider in the differential diagnosis, and splenectomy is usually curative. I've seen occasional case of a true inflammatory myofibroblastic sarcoma of the spleen. But then most often in the spleen, what you see are the non-neoplastic inflammatory pseudotumors. Here is another case of a heterogeneously enhancing mass that was really hot on PET. And most often these are incidentally detected masses. Some patients may have the so-called inflammatory syndrome of fever, weight loss, anemia. And these are biologically distinct from other inflammatory myofibroblastic tumors that I'm going to discuss later. And these tumors do not have the ALK or anaplastic lymphoma kinase gene abnormalities. And on the other hand, it is supposedly EBV initiated or driven process, especially with regard to the spleen. Another flavor of the inflammatory pseudotumor and another classic and target location for inflammatory pseudotumor is the so-called pseudosarcomatous myofibroblastic proliferation, or PMP. It's an indolent benign tumor that occur in older men, as opposed to the other inflammatory pseudotumors that typically occur in kids and young adults. These occur in older men, and these are called pseudosarcomatous because similar to the sarcomas, they extend beyond the urinary bladder. And one of the characteristic histopathological features is the so-called tissue culture, like morphology. And these are characterized apparently due to recurrent ALK gene fusions. Again, there's ALK gene abnormalities is a common theme with other inflammatory myofibroblastic tumor. And now some pathologists would like to call these as pseudosarcomatous myofibroblastic pseudotumors, or the true neoplasms. And these are, again, biologically distinct from inflammatory myofibroblastic tumors, not only pathologically, but also in demographics, because these tend to occur in older men. And one of the common things is that they tend to recur in 10 to 20% of patients. Now, moving on to the true neoplastic aspect of the inflammatory pseudotumors. So whenever we come across, from a pathological standpoint, what looks like inflammatory pseudotumors, so the first thing to consider is that, is it truly neoplastic or non-neoplastic? And many of these true tumors have characteristic gene translocations, particularly involving the ALK gene in almost 60% of all IMTs. So the pathologist can run either immunohistochemistry or FISH test to identify these translocations so that we can establish the neoplastic component of these so-called pseudotumors. They are truly neoplastic because sarcomatous transformation occur in approximately 5% of all cases. And in such cases, the tyrosine kinase inhibitors have shown excellent benefit in these tumors. These are essentially myofibroblastic tumors that has mixed inflammatory infiltrates and a variable stroma. So the stroma can either be myxoid or fibrous, and hence have characteristic findings on MRI. If I have a myxoid stroma in an inflammatory myofibroblastic tumor, it tends to be high T2 signal intensity, as opposed to the fibrostroma that imparts a high PO intensity for some of these tumors. Here is a patient who had a pelvic mass that was predominantly T2 hyperintense and showed intense vascularity. And this was taken out and turned out to be an inflammatory myofibroblastic tumor of the pelvis. So the classic cytogenetics of inflammatory myofibroblastic tumors is that the ALK gene located on chromosome number 2 gets transposed or gets close to another abnormal gene. Either it could be TPM3 or TPM4 or CLTC gene. So when two bad guys come together, you have a deadly combination, and that leads to inflammatory myofibroblastic tumor. So the importance of this led to the development of some of the kinase inhibitors that are targeted towards the ALK pathway. And here is an example of the mother of all inflammatory myofibroblastic tumors, or a sarcoma involving the mesentery, and that turned literally into this following crizotinib, or one of the ALK inhibitors. And sure enough, whenever you have an ALK fusion products, and if you inhibit ALK, you get into the territory of targeted therapeutics. The inflammatory pseudotumor myofibroblastic tumors can, especially in the adults, can involve a variety of locations within the thorax. It can look like a classic lung cancer with infiltrative and ill-defined spiculated margins, or you could potentially have what looks like heterogeneously enhancing pleural-based masses, or in this case of a myofibroblastic sarcoma of the mediastinum, where you have a heterogeneously enhancing hypervascular mass with dystrophic calcifications, or in this patient with predominantly a chest wall involvement of a myofibroblastic sarcoma. Other locations are hepatobiliary. Some of the cases that I've seen in the liver almost look like, a kind of a abscess. More often, I think, looks like amoebic or other pyogenic abscesses. But the classic lymphoplasmacytic infiltrate and the spindle cell proliferation makes the distinction of a myofibroblastic tumor. They can also develop within the biliary tract, causing biliary obstruction. And here is a case of an inflammatory myofibroblastic tumor of the gallbladder. Again, within the abdomen and pelvis, they can occur in the omentum, as in this case, or in the mesentery, as in the prior cases that I've shown, or in the retroperitoneum. So one of the common things is that despite the large size of the mass, they typically show homogeneous enhancement when they're not sarcomatous. When they're sarcomatous, obviously you tend to see heterogeneous enhancement. And another constant feature is the hypervascularity. Again, biopsy is very crucial, and histopathological examination is the definitive way to diagnose these tumors. I have showed you examples of the pseudosarcomatous myofibroblastic proliferation that tend to occur predominantly in older men, but true neoplasms, or the inflammatory myofibroblastic tumors of the bladder, occur typically in young adult women. And here is an example of a myxoid variant. Notice the diffusely T2 hyperintensity of these tumors. Shows heterogeneous contrast enhancement, but notice the hypervascularity. That's a constant feature. If you see a myxomatous stroma, you tend to see T2 hyperintensity and also equally significant hypervascularity in these masses. So some of the myxoid sarcomas can also look like this. So clearly, when they resect and obtain the histopathological examination, they have characteristic findings. Again, they can happen anywhere in the bladder, but the common ones are usually the dome region, where they either present as a diffusely infiltrative mass or an exophytic, heterogeneously enhancing expansile soft tissue masses. Now, moving away from the so-called both non-neoplastic inflammatory pseudotumors and neoplastic inflammatory myofibroblastic tumors, we enter into another category of fibroinflammatory disorders. And here is a 56-year-old man with a presumed pancreatic tail mass. And in general, it's common for people giving lectures to show cases with a fantastic diagnosis as coming from their own hospitals. But they also make a point to show the mistakes that happen in outside hospitals. Unfortunately, this case occurred in my hospital. So patient came with an outside facility study that showed a pancreatic tail mass, and it had some intermediate to high signal intensity on T2 weighted, so presumed to be a pancreatic neuroendocrine tumor. And patient went for distal pancreatectomy with splenectomy, and unfortunately, or fortunately for the patient, it came back as autoimmune pancreatitis. The other part of the fibroinflammatory tumors and pseudotumors is the so-called IgG4 related disease, which is a newly characterized multi-system fibroinflammatory disorder that presents as tumors. And the best thing about this is that it's a steroid responsive disease. And even in steroid resistant disease, when you provide immunosuppression to these patients, these tumor-like conditions show remarkable response. And the classic triad of chronic lymphoplasmacytic infiltrate and the storiform fibrosis and the so-called obliterative phlebitis. This is what they see under the microscope. Not all features may be present in some locations, but in general, these are constantly present, and these features have to be present for the pathologist to come to this diagnosis. One of the important things is that right now that there is elevated, both tissue as well as the serum, elevated levels of IgG4. But right now the thinking is presumably that IgG4 is not necessarily the cause of this disease, but they are constantly present. So it's like a bystander of this process giving rise to these entities. And the so-called type 1 autoimmune pancreatitis is considered a prototype example of IgG4 related disease. As already alluded to, it can involve a variety of distinct organs. For example, you can have it as an orbital pseudotumor, you can have as a submandibular tumors, or the lacrimal glands, or the parotid, or the Riedel's thyroiditis or Hashimoto's thyroiditis is also considered to be part of the spectrum of IgG4 related disease. You can have mediastinitis, retroperitoneal fibrosis. You can have the classic involvement is the pancreas, also referred to as autoimmune pancreatitis. Anytime you have a pancreatic manifestation with associated retroperitoneal fibrosis or renal involvement, as in this case of bilateral severe tubulointerstitial nephritis, there is a good possibility that the pancreatic manifestation is the prototype IgG4 related disease. Here is another case, a 57-year-old man with psoriasis and epigastric pain and elevated lipase. So obviously it looks like he has some peripancreatic inflammatory changes. Notice that there is a hypodense lesion as well. And what is equally impressive is that there is what looks like a halo of fibrous tissue surrounding the pancreas. Notice that there's a hypoattenuating scar around the pancreas. And what's equally impressive in this case is that there are some reactive lymph nodes, and there is a rind of hypodense tissue around it. And this patient also had submandibular gland involvement, and a few CTs earlier, he had proctitis as well. So overall constellation of findings, submandibular gland involvement. This is a case of focal autoimmune pancreatitis. Notice that if this were to be a pancreatic adenocarcinoma, you would have seen much more significant upstream ductal dilatation as well as parenchymal atrophy. And this kind of rind around the lymph nodes is not common. So this is what it looked like following 3 weeks of steroids, in that what we refer to as the steroid whitewash. So clearly the whole pancreas has shrunken, the hypodense lesion has shrunken, and the lymph nodes have gotten smaller, and we no longer see the hypodense rind around the lymph nodes. So autoimmune pancreatitis is a steroid responsive distinctive chronic pancreatitis syndrome with predominant pancreatic involvement, but at the same time, there are significant extrapancreatic manifestations. As already alluded to, the characteristic pathology and serology is helpful for establishing the diagnosis. Here are some classic examples of autoimmune pancreatitis, almost diffuse enlargement of the sausage-like configuration of the pancreas with peripancreatic fibrosis that looks hypo-intense on T2 weighted images. The whole thing shows restricted diffusion, and we don't see any ductal dilatation. As opposed to what we see on ERCP are the diffuse ductal changes, multiple small strictures, irregular strictures throughout the pancreas. So it's almost like sclerosing cholangitis involving the pancreatic duct. Again, sometimes for abdominal pain, some patients would have undergone some other test which would have prompted for PET CT, and clearly in such cases we see a diffuse increased activity involving the entire pancreas. And this is another sausage pancreas with heterogeneous enhancement and a rind of hypodense surrounding the pancreas. What's important to note that there are 2 flavors of autoimmune pancreatitis. I tend to call it as very similar to what we see with Crohn's disease or ulcerative colitis, involving the spectrum of inflammatory bowel disease. So here we have autoimmune type 1, which is a prototype IgG4 related disease. Autoimmune type 2 is non-IgG4 related disease with normal serum IgG4 levels. And clearly you have predominantly involvement of elderly men, 60 plus, whereas the type 2 occurs in 40 plus patients. And there's a significant proportion of patients with ulcerative colitis. whereas extrapancreatic manifestations are more common that involve the biliary tract, the kidneys, or the retroperitoneum in patients with autoimmune type 1 pancreatitis. And frequently, the relapse of the disease is more frequent with the type 1, whereas type 2 is exquisitely steroid responsive. One of the common things that it can mimic, especially when it is focal tumefactive forms, is that of obviously the pancreatic cancer. And clearly, biopsy is essential to establish the diagnosis. For example, this was a large mass in the head and uncinate process with significant ductal dilatation. And notice the normalcy of the pancreas, and the ductal dilatation has resolved following. So this is an important diagnosis to make, but we have to remember that many times we have to have corresponding pathological and serological findings to support our diagnosis. And clearly, it's very heartening to make this diagnosis, because with just steroids, many times you can have resolution of the symptoms. As already alluded to, they typically mimic pancreatic malignancy, and biopsy is essential. And some of the ways that you think, as already shown in some of the cases already, is that you may have a focal lesion, but if you have a normal duct, or if you have corresponding peripheral rind like thickening, you tend to see with autoimmune pancreatitis, as opposed to a focal mass with cancer. There is significant upstream ductal dilatation and atrophy with adenocarcinoma. So once we diagnose, many of these patients respond to steroid therapy exquisitely, particularly with type 2 variants. And it's an important diagnosis to make, because with either steroids or with immunosuppression, you can obtain a good response in many of these patients. One of the classic things is, particularly in type 1, is that they tend to relapse, and high-risk patients are the ones that have associated cholangitis or diffuse involvement, younger age, or elevated alkaline phosphatase. These patients tend to have a relapse. So I noticed that as opposed to pancreatic adenocarcinoma or other malignancies, they tend to come and go and have variable manifestations with these. And clearly, some of these patients may have other complications, such as splenic vein thrombosis, pseudocysts, and chronic calcifications. Notice that again, there can be dystrophic calcifications and differing morphology of the pancreas at different time intervals. And these are the hallmarks of autoimmune pancreatitis. Again, the pancreatitis, any kind of pancreatitis can lead to pseudocysts, and autoimmune pancreatitis rarely lead to pseudocysts and splenic vein thrombosis. So some of the long-term sequelae include the exocrine and endocrine insufficiency. One of the dreaded complications, fortunately it's quite rare, but one of the dreaded complications is pancreatic cancer. So clearly, even despite treatment, you could potentially have significant atrophy of parenchymal atrophy, leading to pancreatic endocrine and exocrine insufficiency. And this was a rare complication of pancreatic adenocarcinoma. in a patient with documented autoimmune pancreatitis. Now moving on to another case, a 78-year-old man, chronic alcohol abuse, fluctuating jaundice, weight loss. So all these are classic presentation of a cholangiocarcinoma. And this was a patient who had intrahepatic bilireductal dilatation. There is duct wall thickening. And on MRCP, there is irregular tapered narrowing of the duct that corresponds to the stricture on ERCP. Notice that there is a T2 dark rind surrounding the duct. And this is how it looked on endoscopic ultrasound, biopsied. And fortunately for the patient, came back as IgG4 related cholangitis. So again, and this patient made significant recovery following steroids. Another case of IgG4 related cholangitis with stricture formation. Notice that even the pancreatic stricture is there, tight stricture with upstream ductal dilatation. And this is how it looked following steroids. Another case of segmental dilatation of intrahepatic ducts. Notice that on ERCP, it looks like sclerosing cholangitis. And this is how it looked following treatment in terms of significant improvement in the strictures. One of the rare manifestations is this, what is known as IgG4 related hepatopathy or involvement of the liver. You could have solitary or multiple liver masses that show characteristic delayed enhancement, suggestive of a fibrous predominant stroma in these patients. So this was a patient initially thought to have a cholangiocarcinoma, and the biopsy results were classic IgG4 related liver disease. One of the common manifestations of autoimmune patients with autoimmune pancreatitis are these renal cortical masses secondary to tubulointerstitial nephritis. And notice the dramatic difference following treatment with steroids. So you can have a variety of renal manifestations with IgG4 related disease. You can have cortical involvement. You can have irregular mass-like lesions, or you can have renal sinus or pelvic involvement. So biopsy is very essential, particularly when there is no associated autoimmune pancreatitis to go with. And it's important to establish the diagnosis. In some cases, they respond well. Some cases, they progress despite treatment. In some cases, they just stay the same despite treatment. So in some of these patients, you can have quite impressive response following either steroids or immunomodulator therapies. And this is another excellent example of bilateral renal sinus involvement with normalization of the findings following steroids. Again, another very ugly looking renal sinus mass with some of these perinephric nodules. So clearly you would think in terms of malignancy. And fortunately, biopsy showed IgG4 related disease, and this is how it looked following steroids. While we are at the kidneys, let's look at another recently characterized mass. Here is a patient who came with a fatty mass in the perinephric area. So clearly it shows fat on in and post phase images. Here it looks like there's some what looks like solid enhancing components, but a fatty mass. The primary consideration is liposarcoma or one of the flavors of liposarcoma. And the biopsy result was interesting. And this is the so-called perinephric myxoid pseudotumor of fat. The pathologist, if you allow the pathologist a long thread, they tend to come up with fancy names for some of these entities. I've seen several other cases where it looks like almost like Erdheim-Chester disease, where there is a kind of rind of soft tissue surrounding the cortex and also within the renal sinus region. And there was another case of what looked like myxoid changes within the perinephric area. And the biopsy results were classic for a myxo-inflammatory fibroblastic mass, and the current nomenclature is the perinephric myxoid pseudotumor of fat. It's idiopathic, sometimes associated with end-stage renal disease or diabetes. So, but again, the key thing is to do the biopsy and establish the diagnosis after excluding liposarcomas. Moving on to the spectrum of IgG4 related disease, up to 2/3 of idiopathic retroperitoneal fibrosis are now thought to be part of the spectrum of IgG4 related disease. It presents as fibrous plaques encasing the aorta and the ureters. And it's important to diagnose this, particularly when the inflammatory component rather than the fibrous component is predominant. When the fibrous component is predominant, then it doesn't respond to therapy, as opposed to when the inflammatory component is predominant, then it tends to show significant interval improvement following steroids or immunosuppressive therapies. Again, in the spectrum of fibroinflammatory disorders, you may have fibrosing mediastinitis and periartitis, as in these patients, where you have a rind of infiltrative soft tissue, either within the mediastinum or in the retroperitoneum or surrounding the aorta, and they can be, quite hot on PET, particularly when the active or the inflammatory component is predominant. So these are the patients that tend to do well, particularly following treatment with steroids or immunomodulators. This case from San Antonio, shared by, I think, the person that most of you know, bilateral renal sinus and periuretral masses. And clearly this type of presentation stumped many people, but not the bright people in San Antonio. Clearly you have renal sinus involvement, and in addition had all these orbital pseudotumors, submandibular gland involvement. So clearly constellation of findings suggest IgG4 related disease, as opposed to some nasty looking lymphoma. So clearly this patient did well following steroids. So in general, there's a wide spectrum of fibroinflammatory disorders that can mimic or masquerade as tumors, and they have characteristic histopathology. There is some overlap between the non-neoplastic inflammatory pseudotumors and the IgG4 related disease. It is important to identify the neoplastic component of these disorders, partly because they have abnormalities involving the ALK gene, and based on that, they tend to respond very well to tyrosine kinase inhibitors that cause inhibition of the ALK pathway. So it's important to establish that diagnosis. And IgG4 related disease, as well as autoimmune pancreatitis, they tend to show very gratifying response and sometimes, and many times, exquisite response to steroids and immunomodulators. The neoplastic or the so-called pseudoneoplastic ones, such as the one that I mentioned about the perinephric pseudotumors, they are either resected or they can just be monitored on follow-up examination. Again, I thank you all for coming, despite having other engagements on a busy Saturday evening in Hyderabad. And I truly thank all the people, including Dr. Kavita, Ishwar Chandra, and others for allowing me to share some of the interesting cases with you. And this is the fun of being in academic radiology, is that, you know, as opposed to just doing certain things that will sustain your livelihoods, you also tend to make a remarkable difference to the lives of patients. Thank you very much, and I'm happy to take any questions. I will stop sharing.
Yeah, sure.
I think I stopped sharing.
There are